Have you looked at the influence of rehabilitation or activity on these peptides? Is it the same as when you introduce rehabilitation or activity to the chondroitinase treatments that you've worked on before?
That's a really important question. The question is, what about adding rehab to the peptide? Those are experiments that are ongoing as we speak. So we do have a robot in Cleveland, a treadmill type of robot. So we're going to train the animals to see if we can get some of the non-responders back to responders, or bring up the responders even higher at an ultimate level for all of them. So we're going to add rehab. Our thinking is, for sure, rehab is going to be very important.
Can I ask you a question?
Yes. I'm glad.
Jerry, when you inject the peptides, have you tracked where they go?
Right.
And what amount actually get to the cord?
Can everybody hear the question?
So he wants to know where the peptide goes. So right now we're doing HPLC analyses of all the tissues in the body. Our impression right now, using a biotinylated peptide, is that it goes just about everywhere. It's going into the spinal cord, into the brain. It's going all over the body, and there's DMSO. So, but how long is it present? We think probably a very short time, because it's a peptide, and it probably breaks down relatively quickly. So we're giving bolus injections of a peptide that turns over very fast, we think. But how it works, we don't know.
Okay, I have a question, a couple of questions. One for Damodar. Have you, a question and a suggestion. Have you ever thought of, or do you take maybe a laptop computer that has some, this conference, for example, on the computer, that you could take to some of the people in Nepal and show them some of the promise of the research that we've seen today?
Yes, actually, most of my patients, they keep on asking what is really going on in the far Western world. So I've been dealing with them and explaining them. And those who are interested, I just give them the website where you have videos and photos about the research thing. They keep on reading from that as well.
Very good. And then a question that I have for Jerry is that when we saw the growth of those axons across an injury site, were those motor axons or sensory axons?
Okay, so I showed you growth in vitro.
Right.
Across the spot rim, which is a very difficult hurdle to overcome. And these are adult sensory axons. The reason we use adult sensory axons from adult sensory neurons is because we can get them from the adult. They don't need trophic support. And so that's one of the few homogeneous populations of the neurons we can get from the adult that we can test in our assays. We don't want to use embryonic neurons, which many people do, because they don't obey the same rules. So we use sensory neurons.
Is there a way to get motor axons that you could do that experiment?
No, we couldn't, because they die. It's very difficult to get adult anything out of the nervous system, but we can get purely very old sensory neurons and test them. It turns out embryonic neurons don't have the receptor, at least in high abundance. That's very important. And they do not become dystrophic in our assay. They turn away because they don't have the receptor. They probably turn, due to some of the things that Ravi has been studying, probably charge effects or who knows what else. Proteoglycans have these kind of a dual kind of sided sword.
Any questions from the audience? Oh, here we have one over here.
I have a question for Damodar.
Oh, wait. It doesn't seem to be working.
I was wondering why only a third of the people with injuries go to rehab.
Pardon?
Why do only a third of the people with injuries go to rehab?
Okay, actually the system in my country is like rehabilitation process had just been started, just a decade back, about physical rehabilitation thing. And most of the surgeons, sad to say, in my country who are dealing with SCI, the time they deal with the patient, they feel that rehabilitation process is not important. And other thing is the literacy rate of our individual patients is really low, and they don't have much idea about the rehabilitation. And other thing is about the cost, because most of the patient, they belong to countryside where they cannot afford the process of rehabilitation. though we provide charity for the patients who are really in need, but it's still, due to lack of knowledge and about the process of rehabilitation, they don't make it much. Thank you.
Boy, I tell you, the big elephant in the room for everything about this in the United States or Nepal or wherever it is that SCI is just, research is so, in general, is so underfunded that we need money on every level, it seems, to really make the kind of progress or help people that need it in Nepal and other countries around the world. Are there any other questions?
Yes, I've got a question for Ravi. On your lipid microtubes, you know, you've got the thermostabilized chase up to about 30 days. My question is, do the other scientists think that you need more than 30 days for that stabilization, or is 30 days going to be enough? So I guess I would like that question to both Jerry and Ravi to get kind of a consensus if 30 days is enough, and maybe Oz would speak to that too as the combination therapies come around. Is 30 days going to be enough, or do we need more?
Well, it depends on the model that you're talking about. If you're talking about a hemisection model and wishing to promote plasticity of remaining fibers, I'm ecstatic to hear about 30 days. Because we see restoring a function in the respiratory model within 7 days. But then you showed nicely that the proteoglycans are coming back. And so if we could keep them away for a month with just a single injection, I think that's spectacular. That's in a plasticity. Now, in a complete or very, very severe contusion model, we just don't know what the answer is, how long you'd want to have proteoglycans digested. And you don't really want to go back and inject over and over again. Now, I know in the United Kingdom, there's a very, very strong effort now to use viruses to deliver chondroitinase. But of course, then you have the issue of the virus in the brain. And if you've got a thermal stabilized chondroitinase that can last a very long time, I think that's really, really very exciting. But how long, and will the chondroitinase by itself in a contusive injury setting in the chronic state be enough? And I would venture to guess it's not. We're going to need bridges and other therapies, combine all of our expertise, work together, collaborate, you know, and come up with the ultimate combination.
Pastor Rob.
Just to add to that, the technology of either the tubes or the shells both lend themselves to doing multiple agents. So we don't have to do only one. So if we want to combine it with an siRNA construct or a trophic factor, so it does lend itself to doing both. So our interest is to help develop tools to modulate with minimal invasion. The reason we got into the thermostabilization is to help us, do that with minimal invasion instead of these long indwelling catheters and such. But there's nothing stopping us from combining that with NT3, as we showed you, or with other agents that Jerry alludes to promote growth.
So So I think, in my mind, a really exciting experiment is going to be in the chronic setting to wake up axons that are stuck with probably a chondroitinase and or chondroitinase plus a neurotrophin or some other trophin to get the axons going. And then once the axons are going, we can add our peptide for as long as we wish, simply, via systemic route. So we may be able to go much, much longer. But my guess is it's going to be a chondroitinase plus peptide therapy, at least for that part of the story, which could be optimal.
Actually, if I may just ask Jerry one question, or maybe Oz or somebody else in the audience. Do we know in the chronic state if the blood-spinal cord barrier is still open or not?
It largely closes after about 2 to 3 weeks to big molecules, but then it stays open for long periods of time to small molecules.
But there are lots of proteins from blood that maintain the inflammatory state for a long time that leak out, as you said. So I think the advantage of some of the nano carriers is that you may still be able to, through intravenous injection, get to the cord in the chronic state. But that's an experiment we're doing now. So in a year, I'll know what the windows are for a 100 nanometer sized gap. Or now we have 60 nanometers as well.
Okay, we have
Dr. Silverman, you mentioned respiratory therapy or treatment.
Yes.
Do you feel that that might be the first step, that your peptides may be a benefit? People like C3, that C4, where they have partial diaphragm paralysis. And how soon, the other question, how soon do you think that first step towards a cure for getting people off vents and preventing pneumonia, how soon do you think that may be available?
Well, that's, how soon is we have to speculate about how soon, but all I can tell you is that in our respiratory model, which is a C2 hemisection, which is similar to what you're describing, you have one lung if you're a rat. We know that a single injection of chondroitinase, one shot, and it's not even heat stabilized, can restore about 40% of phrenic nerve activity in a week. And that's at chronic stages. And the reason that occurs is because there are these cross projections that are sitting there, socked in by perineuronal net that refuse to sprout. But when we add the injection of chondroitinase, even a year and a half after injury, respiration improves dramatically. How soon could we do this in a human who has some respiratory insufficiency, right? But you don't want to also kill that patient. And we would have to show safety beyond all measure, right? That this enzyme does no harm, simply injected, right? And then I would hope to move to a larger animal model and as quickly as possible to human.
Doctor, I saw my son struggle and get put on a vent 3 years ago. And it took 10 days to get him off the vent. And they didn't even want to get him off the vent. They were afraid he couldn't recover.
Yeah.
And, any bad cold, any pneumonia, takes a C4, C3, C4 patient and puts him in great jeopardy. And I understand to do no harm. But, you just say to yourself, in those events, maybe there ought to be people that volunteer for things.
Yeah.
Give choices to patients.
I agree. I mean, this is where our peptide, God willing, and it shows efficacy in chronic injury, or even at acute stages in our respiratory model. When we get the right dose, then we don't have to touch the spinal cord at all. And I can't imagine if this peptide is safe and found to have no, really horrible side effects, that we couldn't at least simply systemically inject and see what happened.
That would be one of the first steps.
Well, we're pretty excited. So we've got our respiratory model. We're working on the right dose. See, we have responders and non-responders. We want them all animals to respond as best as possible, and then we'll use that dose at first in our respiratory model. See if we can bring back breathing without even touching the spinal cord.
Okay, we have 2 minutes left. Any other questions? Oz has a question.
I actually don't have a question, but I did want to make a comment on it. And actually going back to one of the comments earlier today about why all of us scientists don't get together and do kind of a Manhattan Project kind of thing, and it's it's a really good thing. So let me lay down a challenge here and think about what that would mean. You've heard us earlier talk about the regeneration strategies. You've heard these folks talk about other strategies to change the site of the injury to make it more hospitable to growing axons. And everybody is telling you that we need to do more experiments, just what Jerry talked about. We need to look at the timing and the dosing, and then we need to start moving into larger animals and see if we can scale this up. So what would it mean to actually have a Manhattan-type project? And let me just put this in the perspective of the California Institute for Regenerative Medicine. So some of you may know I'm on the governing board of that, and John Thomas will be talking to you tomorrow and tell you about that program. $3 billion over 10 years, and things are moving forward. And the kind of things that are particularly important are the disease team grants, which are up to and sometimes even a little bit over $20 million apiece to target a single problem. This is what it takes. So let me just throw a number out there and a challenge. I think $1 billion would be a conservative estimate of what it would take to do the kind of thing you were talking about this morning, about really making it possible for all of us to stop writing grants every 3 weeks, really be able to take our research to the kind of very practical level where things, you can't publish exciting things if you're just doing different doses and so forth. But we could do that if we had the money. I think that's a number that might be a reasonable number. But I'd love to hear other people's comments about that.
So yeah, that's a reasonable comment there, Oz. And my question to that, or retort to that, would be: is where's the plan? If you build it, they will come. But in terms of the money, where's the cohesive, globally collaborative plan for that? People aren't just going to say, here's $1 billion blank check. They're going to say, who's running the show? Who is the CEO? Who's the Oppenheimer? You reference, like, we don't, who's Oppie? Who's General Groves, the guy who actually ran the Manhattan Project from the military end of things? Who's running it, and what's going to be the motivation of the individual scientists on running, actually doing the science, in the physics comparison to the Manhattan Project? So if that's there, I don't think the money it won't become the issue.
Okay, I think that's a really good question, and I would actually put it back onto the model of the California Institute for Regeneration. What came first, the leadership or the money? And the answer is the money was needed to bring the people together to think together about what to do. There's not going to be a single person who stands up and says, I'm going to lead this, right? Because we all have very different attitudes and ideas, and I think different approaches that are very, very reasonable. But if there was a possibility of actually coming together and funding a really, really imperative group effort, we could come together and actually come to a consensus opinion of what to do. But again, I think it really has, you have to have that possibility, that vision out there that the money brings, and then people would be willing to do it.
Oz, we're going to have to stop right there.